All right, welcome to Metro Health Matters. This is our new podcast that we're doing together,
Exciting.
and we're so grateful. We have Dr. Tabia Akintobi, and we are going to be talking about all of her work at Morehouse School of Medicine and her new book and all these good things happening. But we really wanted to also be thinking a little bit about this Archie breakfast coming up, on kind of thinking about the path that we've had in Atlanta from
Yes.
redlining to some of our really distinct and difficult health inequities these days.
Yes.
So we wanted you to come and share your expertise and just expose all the great work that you're doing, lift up the great work that you're doing. This is a series that highlights the people, organizations, and partnerships working together to create practical solutions and lasting regional health impact. And thank you for joining. Thank you for joining us today for Archie. Archie is the Atlanta Regional Collaborative for Health Improvement, and thank you for just doing all of the amazing work that you've been doing in the community and just the friendship and
Oh,
support that
yes.
you've shown me over the years. I
So
really agree. I'm grateful for that.
so glad
So
to be here.
yeah, we want to talk about all the wonderful things. And I wanted to start with your book, right? I know you don't want to start with your book, but I want to start with that because I do think I've had such learning in terms of your how you've really centered community in
Yes.
research, community in public health, community in everything we do. A lot of the reason I think we do what we do in our community of practice, trying to put our community members more at the center of governance, is because of all of this work and research that you've done. Like, how do we put community voice at the center? So, I
Yes.
wanted to ask you to talk about your
Mhm.
book, and for listeners who may be hearing about community centered public health for the first time,
Mhm.
what does that mean, and how is it different from how kind of public health was traditionally practiced?
Yeah, so first, Jeff, thank you so much. And we're so excited to have Archie as a partner for many years now. And
Yeah.
as we scale, the importance of amplifying the work that we collectively do is important. So there's so many parts of public health, and we're very clear that every single part matters, from the biostatistics to the epidemiology to the environmental health. All of those things matter. But traditional public health has frequently positioned communities as those that react to
Mm,
something that frequently we have created
mhm,
as academic institutions, speaking for Morehouse School of Medicine, or agencies. They community residents really are the ones to react
mhm,
versus those that actually
mm,
co-create the research questions, the programs from the beginning. And so community centered public health really starts with a different premise, and that is that they should set the research agenda, the public health practice ideas. They should co author the results. They should be the ones that get funded to do the work. And we know all of that is a heavy lift. But the shorthand that I use is the difference between community engagement as a box that you check,
mm,
or to say that someone is at the table, versus it being a part of a structure that you not only value, but that you invest in to ensure that there's community credibility and really durability in this public health work that we say we're trying to do.
yeah. I
Mm-hmm.
mean, I mean, I feel like I've learned so much
Mm-hmm.
about not just kind of, like you said, not
Mm-hmm.
just checking a
Yeah,
box,
yeah.
about really trying to kind of make sure that voices are not just kind of advice, but the like you said, co-creating
Yes, yes.
that this is kind of at the center of the work,
Mm-hmm.
and that it's not just kind of an afterthought or a box that you check.
Mm-hmm.
I mean, I know I didn't talk about this ahead of time, but like
Mm-hmm.
what has that learning journey been like for
Oh
you?
my.
Like it's like so much to like you've been doing this so well for so long, but like how has this learning journey been for you?
Well, it's really been a journey of humility and recognizing that even in the field of public health, this community centered work, I know you know, Jeff, is really the path and the road less traveled.
Yeah.
I like to call it
Yeah.
hard work.
Right,
So
right.
when we even hear the term rigor, when we think about research and the ways that we respect research and public health, this really is that rigorous work. It is not easy. And when we think about developing paths for folks to do it behind us, we need to get past talking about what it is, why it's important, to how people do it. So for me in my journey, it's required really a core premise, and that is relationships, whether it is between an organization like Morehouse School of Medicine and a community-based organization or community residents. It's about relationships. People stay in relationships because the other partner has figured out what they care about, what they value, and has chosen to pour into that over time. You know, Jeff, that's why we stayed in relationships.
Yeah,
There's
yeah.
something that you value that I've figured out, and vice versa. So if we treat community-centered public health that way, it really is about relationship building when there is no grant, when it is after 5 o'clock and on the weekends. But really, the results of those processes reap dividends that include the money, that include the partnerships, that include the policy partners. My journey has also been about recognizing that this work is not specific to one health condition or disease state.
We tend to do that.
Yes, so it can't be about HIV or necessarily maternal and child health. It's about partners who are like-minded, and that their partnership can be transferred to whatever the public health issue of the day is. We found that out through the pandemic, and we're finding out thereafter those relationships that really have sustained over time, that are community centered, have transcended health conditions, and we can apply it to something else.
I love it. I mean, and I'm remembering when you and I worked together, you had again been gracious to kind of show me how you do things. But when we were talking with members of the community who had experienced kind of the hospital closures right here, right close by, and I remember this notion of like, I don't want to be studied. I don't want to be, asked more questions.
Yeah.
I want to know that someone cares. I want to know that someone's doing something.
Right. And, I remember those rooms that we were in. It was definitely after 5 o'clock. And, it wasn't necessarily as comfortable for us, but the value proposition was people being in spaces where they were heard, but also knew through organizations like Morehouse School of Medicine and ARCHI that we were going to figure out a way to do something.
Yeah.
And I think that is also the value proposition for most. It's not just coming back with the data, which I think is still important, but people want to know that there's going to be action to their community wisdom, which sometimes that's the data that we gather. My community wisdom should be informing something.
Yeah.
And that something ultimately is, there should be things that they're actually a part of.
Right.
Yeah.
Action.
Yeah.
Central theme of your work has been moving from community participation to community leadership. And you've talked about this already, but anything else you'd want to share in terms of that shift and kind of what changes when you put communities in the driver's seat?
Yeah. So, participation can still mean that someone else sets the agenda.
Right?
Imagine
Which
that.
is hard.
So I can participate and come to a meeting as a community resident, but someone else has set the agenda. I might just be invited to react to it. Leadership means agenda setting itself sits with the community. That's one of the ways that the shift happened. Yeah. And what changes also concretely, Jeff, is who reviews and approves the program or the idea. Again, who co-authors it, who is funded to do it, who gets paid for their expertise, not just their time.
Yeah, right.
Who has the real veto power, not just a seat at the proverbial table. Yeah. We should be moving past someone, looking around and seeing who's in the room. That really is step one. Yeah. What happens with that information? So when that shift happens, the questions being asked, Jeff, they also change. I've seen the amazing work of ARCHI, and who is in the room and who sets that agenda changes and really helps to surface the issues that I, at an academics institution, may not have thought about. Right. And then finally, I think most importantly, it changes trust and credibility. The results and the programs that communities co-own tend to outlast a single grant. Oftentimes, they reflect communities that may be fiscally less buoyant, but they've had to live through innovation. And so when they are at the helm and they really have helped to create something, it really supersedes any single grant that any of us could apply for together. So that leadership also includes typically those policy leaders that, I mean, first time I went to the DC Hill, it was with a community partner because I surely didn't learn that in school, right?
Right.
And so they are more likely to galvanize those people that we should be thinking about anyway from the beginning. Those policy folks that can hear and help us to act. So that leadership, I think, really results in trust and then durability of the public health that we're doing. That credibility, which matters, trust and trustworthiness.
I mean, just I know you said this at the beginning. It's just this: who sets the agenda?
Yeah.
Yeah, I appreciate. I mean, because guilty. Like
Yeah.
sometimes we are not necessarily doing that work, like you said, the hard work to really say, no, 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 no. It's not. I'm not inviting you to a room where everything's kind of orchestrated
Yeah.
already.
Yeah.
Let's co-design. Let's like, or you tell me what you want to study, and let's go from there. It's not. It's not. What does Jeff want to get done?
Yeah. And some of that is about certainly us creating those spaces. And I found across this journey that it takes time for community residents, despite their amazing leadership in the community, to know that this space is really for you to lead it.
Yeah.
Sometimes
Right.
it will take time for them to really trust that
Right.
that's what we're
Yeah.
trying to do.
Yeah.
And so that means that you cannot have a deadline for submission of some plan next week and start just the week before. I mean, I say it because I
It
tried
happens. Yeah.
so you have to build that time for courageous space and place for people to feel comfortable to unpack who they are. Again, relationships. So that means there has to be an investment in that time, and that investment includes not only clock time but also human and physical resources to say that who you are is what matters even more than what you bring. That's a value and a behavior that we're all really watching, whether we think about it or not. We're all looking for those relationships that demonstrate those values, and those are the relationships that tend to last.
Yeah.
Yeah.
That gets us to sustainable change.
Exactly. Yeah.
Talk about I mean, we talk about inverting the burden at Archie a lot in terms of really thinking about how our systems designed, and in many cases, these are systems that have been designed over decades or centuries to specifically push some people out or say, I don't, you're not as important as this population over here. And let's be real, in Atlanta, that has been very racially motivated. That has been, if you're black in Atlanta, your health care, you do not have the same health trajectory as if you're white in Atlanta. That's just a fact. I mean, we can look at that data after data after data. But talk about how the concept of inverting the burden, with your vision for community-centered health, community-centered public health. Talk about kind of inverting the burden in that realm.
Yeah. And so I recall when I heard the term the first time through ARCHI, and I said, "Yeah, that's what we're trying to do."
We're thinking, right?
And so systems routinely ask the people with the fewest resources and who really are the end users of broken systems to do the work.
Right.
And all they're trying to do is survive these broken systems that they did not create. So they navigate fragmented care. Um, they have to travel farther for services, all of these things. So community-centered public health, inverting the burden, responds by relocating responsibility, asking us as institutions and systems to change how we operate rather than asking already burdened residents to become experts in working around us. And so that means the accountability to fixes lies on us, and that is how we as public health really center community. And so again, I have to say that these governance structures really help them to keep us accountable to ensuring that we're doing that and not placing the responsibility back on. So it's recentering the account, relocating the responsibility on us to fix this. And as you said, Jeff, this did not start overnight. This started long ago. And so we hopefully are all contributing to that, but it's not going to be undone with one organization or one entity. So that's why ARCHI is so important.
And all the work we're doing together, right?
Yeah.
Well,
Yes.
let's talk a little bit about redlining, right?
Hmm.
So, one example of systems placing burdens on communities is redlining,
Yeah.
and for listeners who may have heard the term but don't fully understand it, or I'm going to add kind of make the connection to health
Yes.
outcomes now. Like we think about, we invest so much in healthcare in America. We invest billions in healthcare in Atlanta, and yet we are still in many cases have some of the worst health outcomes across the nation,
Yes.
and worse health outcomes for kind of more developed, if you are countries. Talk about kind of that connection, right? Like talk about redlining, but also talk about connection to health.
Absolutely. So, just like, the stories or the realities of the Tuskegee Airmen and
Hmm.
Henrietta Lacks, people hear redlining and they know it was a bad thing,
Hmm.
but they don't really understand the
Right.
connections and the mechanics of it. So, redlining as a practice, it was systematically, as you described, denying credit and insurance access for residents of specific neighborhoods, often by race and ethnicity. And so it was in 1934. It was formalized by the Federal Housing Administration, and it involved literally the Homeowners Loan Corporation developing these maps that were really used to literally grade neighborhoods. So as you might suspect, neighborhoods that got an A grade were in green, or the GO, healthiest, best neighborhoods. B would be still desirable. C would be declining or yellow neighborhoods. And D, hazardous, were colored red. Redlining. That's the origin of the term. So the practical effect, Jeff, is that residents in degraded neighborhoods were disproportionately black and immigrant communities then, back in the 1930s. They were denied mortgages and home improvement loans for decades, even when they were individually credit worthy. So it graded place, not the person, and place became a proxy, quite frankly, for race. So we know that it was formally prohibited under the Fair Housing Act in 1968, but prohibition didn't reverse the disinvestment in it already compounded into those neighborhoods for over 30 years, and that pattern has resulted in lower quality schools, infrastructure, and so many other things. So I know we're going to get to the implications for public health here now. So when we think about metropolitan Atlanta, Atlanta's own neighborhood boundaries still trace back to those maps in many corridors. The same lines that decided lending decisions in the 1930s and 40s show up in where investment, grocery access are concentrated. So because homeownership has historically been the primary vehicle for American family wealth building, being locked out of mortgages for decades didn't just affect housing, it interrupted intergenerational wealth transfer entirely for those families. And we know in public health that housing, particularly in Atlanta and certainly in our state where we're hot and number one for all of the wrong reasons. When it comes to public health, this disinvestment didn't stay contained to housing. It shaped the food environment, right? So when you think about those social drivers of health, we're talking about fewer full service groceries, more food deserts where you might find, in gas stations, a few overripe bananas and everything else with a label. When we think about transportation, the transportation environment, less reliable transportation, longer commutes to jobs and care. And then there's a built environment, more heat exposure, more industrial siding, and air pollution. So all of this, as you hear it, this historical decision has implications for today and is directly connected to all of the social determinants, or depending on who you might be funded by, the social drivers of
Right.
health.
Right.
Yeah.
Yeah.
Mm.
I mean, and thank you for the connection. I'm thinking
Yeah.
about back in my past life when I worked with
Mm-hmm.
older adults, and a woman that I was working with at Meals on Wheels who just shared, like, if I want to, she in West End. We're not talking rural Georgia.
There,
We're
yeah.
not talking even suburban Georgia. We're
Mm-hmm.
talking like, you know, in the middle of Atlanta,
Yes.
having to take two buses to get to a grocery store where she could get to fresh fruits and vegetables.
Hmm.
And so, because that was so hard and because of her mobility challenges, she never got to the grocery store, right?
Right, right.
And so then she was on wait list, and so we thank you for making that connection
Hmm.
in so many ways, and how these decisions of the past and these policies and prejudices and practices have gotten us to where we are today. And
Hmm.
because I do think there's sometimes, I don't know, my soapbox for the moment is that people scratch their head, why can't we do this, why can't we get better health outcomes? Well, we do have to look at our history, and we do have to look at how we got here, and how neighborhoods, as you said, very specific neighborhoods were cut out of opportunity.
Yes, yes, absolutely. And so, all of those have pathways to chronic disease when we think about just like the lady you talked about. She has every reason to not go to the grocery store. It doesn't make sense
Right, right,
because of the time that she doesn't have, the
right.
funding that she doesn't have. So, for those reasons, the likelihood that she is going to be eating fresher, healthier foods is going to be reduced. The likelihood that she would take those two buses not to the grocery store but to see a doctor that she wants to is going to be reduced. So she may not be managing her diabetes or hypertension, all those things that are comorbidities that work toward disproportionate hospitalization, illness, and death at the end of the day. So there's been national research on historically redlined neighborhoods and found that in those neighborhoods, the life expectancy is vastly different, up to several years, up to multi decades, depending on the city and comparison. And Atlanta specific reporting has tied local disinvestment, as you know, to measurable gaps in life expectancy by neighborhood. So what this tells us is that the core social determinants or drivers of health, the argument is that zip code has told us just as much, if not more, about health outcomes as genetic code. That's a whole other discussion.
Right.
When we think about what's inside you versus what is around you,
Right.
what's around you, um, helps to determine in many instances your health outcomes more than what's inside you.
So how what do we do about it, right?
Yeah.
And what from your perspective, what does it look like to repair harms created by redlining and other structural inequities in a
Mm-hmm.
way that is truly community centered rather than simply create, and you talked about, like,
Mm-hmm.
oh, it's a new grant or it's a new initiative, and I appreciate,
Yeah.
there's, hey, we need new grants and new
Yes.
initiatives, but we need sustainable system change, right?
Mm-hmm.
How do we get that truly community centered and structural equity in moving in the right direction in a way that's not just a program or an initiative?
Yeah. Well, I'll start with just the last part of your question, and that is we need to co-create with federal funders who are beginning to ask us more and more what should be funded, but also with private donors and those who, when we're mission and vision aligned, they will fund those things that we prioritize rather than funding specific initiatives and programs, understanding that a part of the investment needs to be in the infrastructure, and addressing these partnerships between local businesses in the community that may need time for the business case to be made to them, that they should consider offering fresher fruits and options, fresh fruits and vegetables that are at a lower cost because the community might say that they might buy them.
Right.
That might not be a research study,
Mhm.
uh, but that's a relationship with those in the communities that people don't have to take two buses to, that may also need an investment to be able to be that resource for good
Right.
rather than harm in the community. So that's one thing. But repair also requires structural change. And that means shifting who holds decision making authority over the resources going into a neighborhood, not just
Yeah.
delivering resources to it. It also concretely means community ownership models like, and we've seen this in other places across the U.S., land trusts,
Mm.
resident government resident governed boards with review and approval authority, co-investment where residents can help direct how dollars are spent. We have a few initiatives like that in the city more are important, such that there's a real understanding that the infrastructure should be funded, but also addressing that harder work on the social drivers of health are important. And that means that work can't just be 3 to 5 years long, Jeff. We need more time
We get have time,
to
yeah.
co-create, ideate, and figure out who
Right.
needs to be at the table and build in a policy-focused areas,
Yeah.
relationships with local policy leaders who can help to take what we're hearing and move it into actual change. So none of that's a single project or initiative, but funding the social drivers and those players that need to be in the same room to do important work together. That changes even the funding model.
Yeah.
Yeah.
And I appreciate your connecting the dots on policy too, because I think personally that's yeah something that I have not necessarily put as much energy into is I mean that's how things change. One of the main ways that things can change is to really think about like what are the policy connections and who's making those decisions and how do we make sure that they have those connections to the community to be able to make change. Um, I want to ask what you're excited about. Like, talk about the kind of when you think about the future. And I know this is heavy, and this is I don't mean to make light of any of this, but I also know that you're doing such important work, and you're doing some really exciting work. Like, what are you excited about in the future? What's bringing you joy when you think about the future of Atlanta?
Yeah, what really excites me is that, for the first time, we are really marrying individual or even family-based programs to those that address the community level drivers of health. So, for example, we have one initiative that is based in Fulton and DeKalb counties and in Macon and Bibb County to address diabetes prevention, which again, we are very hot with respect to diabetes prevalence and related comorbidities. And so we are implementing an intervention with community-based organizations who are getting funded to deliver an intervention that's focused on diabetes, that's not focused on the individual, but on parents and children in the household, because we know parents likely will sustain and model behavior if they're doing it for children who may have some of the same comorbidities or challenges. So that's nice. And we got a lot of community feedback towards that focus, not just on the individual, but the social and familial bubble. But through that same project, we were focused on the community level. And so we're training through groups like Georgia Watch, training community ambassadors to know what civic engagement effectively can look like. And I say that with emphasis because I also needed to be trained. Yes, I'm passionate, but how can I do it in a way that my local policymaker will say, yes, this is what I need to do with you. I will take you to the local or state hill to do it. So there's the individual programs, but the opportunity to train community leaders to be able to advocate effectively is that community level social driver. The other piece that's really exciting to me that we learned a few years ago after doing a community health needs and assets assessment over many, many years, mental and behavioral health has emerged in 2018 and since then as a primary health priority. And, it was great to see that. Not great that it was an issue, that finally people, Black and brown communities were saying, I'm experiencing this, or I'm seeing it in my community. And so offering mental health first aid training to folks across the state has been really exciting. No, it's not a research project, but it is arming people with what they need to be able to see, identify, and support, and be those basically health officers of their community, and helping us to realize there's no health without mental and behavioral health. And particularly, Jeff, in this time post-pandemic when we're dealing with so much politically and socially, minding our neck up health is absolutely essential. So while that wasn't on our regularly scheduled program, I had to put it in there.
Absolutely,
because we're dealing with a lot.
Yeah.
And, the importance of leaning into each other. I remember a few years at the American Public Health Association, social cohesion was the theme of the year.
Right.
And it's a reminder to us that we're not only doing this with the communities that we care about and that teach us how to better engage them, but as those who care deeply about community centered public health, we must mind. We must mind our health.
Yeah. And I love, I'm thinking about, just as you talked about, just the civic engagement training,
Yes.
but that's connectedness to belonging, right? And this whole
Yes.
sense of like, how do I feel a part of a community and feel like I'm heard,
Yeah.
and that I have folks that I can talk to,
That's
and
right.
I'm not isolated. The isolation is so,
Yeah.
that, like you said, neck up.
Mm-hmm.
Yeah.
Mm-hmm.
Thank you. Well, okay, I think we hit, I hopped around. Anything I missed though that you want to share? Like,
I think we covered most of it. But one thing I would say, just as something I continue to remind myself, and it's really on this note about agency, right?
yes.
And motivation. Um, uh, this is not about diagnosis. This is not a fixed history when we think of things like redlining and the importance of community-centered public health. Governance structures already exist in Atlanta that prove a different community-led way of doing this work is possible now. So there's some things that have already been working and are very simple organizations, whether they're MPUs or the Georgia Community Health Workers Association, many others that have been here. We need to leverage them and not think we have to create everything from scratch.
Right.
We're working too hard. I think the work is already hard.
Right.
So
Right.
how can we lift lighter together?
Yeah.
And so conversations like this, and certainly ARCHI's work and that which we're trying to do with Morehouse School of Medicine, is a way to remind ourselves. Let's think about those simple things that always work, and that is learning the strengths of others, how we can fill some of those gaps to invert the burden and advance population health.
Any last shameless plugs you want to do for your work, for Morehouse School of Medicine, any events, anything that, and you know, this is a chance to shameless plug if you have any.
Yes, so Community Engagement Day happens every year at Morehouse School of Medicine, and it's really a reminder to us in the community of what we try to do the other 364 days of the year, and that is to celebrate the people and the partnerships that advance health equity and population health. October 3rd, 2026. We know ARCHI and others are already there. Let us celebrate, as you talk about, what am I excited about? How do we celebrate those people and partnerships? So go to www.msm.edu and you will learn more.
Awesome. And we're going to put that on the podcast too, so that people can follow a link. But thank you. This has been awesome. Thank you for the modeling that you've done, the mentoring, the kind of example that you set for so many of us that are trying to figure so much of this out, and just all that you're doing with community, on behalf of and centering community. I really appreciate that. And just thank you for this time and being willing to come be a part of this new podcast, Metro Health Matters. And I'll just repeat kind of the purpose is to highlight the people, organizations, and partnerships working together to create practical solutions and lasting regional health impact in Metro Atlanta. So thank you for being a part of this from the beginning here.
Thank you for the platform, Jeff. Thanks for all the amazing work and our partnership.
Absolutely. And more to come.
Yes.
Thank you.